very important that we are aware that patients who are already on non-vitamin K or anticoagulation, if we have that patient who suffers an acute ischemic stroke, we have to deal with the patient the same as the patient is not anticoagulated. So we have to do the immediate CT scan, CT perfusion, and the CTA. So if there is a large vessel occlusion, we can easily do the mechanical thrombectomy in those patients. So as in every patient with an acute ischemic stroke, we have to have in mind that actually time is brain. So we have to be very fast. We have to have in mind that we have the reversal agent, especially about that patients on dabigatran. So we don't have to wait, to get the results about the hemoclot, so about the anticoagulation status. So it is much better to treat the patient, to give patient the either racizumab and thrombolyze. And we have a lot of data, not just from the multi-center randomized clinical trials, but we have the everyday clinical data, which are published in the literature. And we have to be aware that we can help those patients. If they suffer acute ischemic stroke, we have to treat those patients. And I think that in the majority of countries, the reversal agents are on the market. And actually, we have to treat those patients. About the intracranial bleedings, it is the same. So there is also time is brain. So we have to have in our mind every day that when we have a patient with the intracranial bleeding on the non-vitamin K or anticoagulation, it is important in the acute phase to prevent the growth of the hematoma and then to lower the blood pressure, of course, to give the analgesic and to treat the patient also with the surgical evacuation if it is possible. So with the reversal agent, it is much easier also for the surgeons. So the reversal is done in a very short time. And it is also safe to operate those patients with intracranial bleeding. So those patients have future. And as we can also see from the randomized clinical trials, the mortality rate in patients on the NOACs with intracranial bleeding is much lower compared to the mortality rate, which is well known in patients who suffer intracranial bleeding on warfarin. So they still have a very high mortality rate, but in patients on NOACs, the mortality rate is definitely lower, especially when we use the reversal agents. So there is future for those patients. And of course, it is the most important for the neurologist that we try to give the patient back to everyday clinical life. And we do know that, as I said, the mortality rate is much lower and also the functional status. We are evaluating those patients with a modified Rankin scale. And actually, as presented in the biggest cohort that was published by the German neurologists, they actually have the biggest cohort of patients on dabigatran who suffer acute ischemic stroke. And they got the IVT after reversal with either racizumab, and also the patients on dabigatran who suffer intracranial bleeding, and they were treated with either racizumab. They published 80 patients treated by IVT and 40 patients with the intracranial bleeding. And we have also done a very nice research at our department at the University Medical Centre, and actually evaluated all the patients who got the IVT and also who were treated with either racizumab, and we got comparable results. So the mortality rate in patients with the intracranial bleeding was around 15%, which is, let's say, very low for the patient who suffer intracranial bleeding, and it was compared to that reported in the German cohort study. And also the functional status, so the Rankin score at the discharge was actually much better compared in patients who suffer intracranial bleeding on warfarin. So a good functional score for the intracranial bleeding is when a patient has a modified Rankin score less than 3. So around 60% of patients in the German cohort study and also in our cohort had an MRS score less than 3, which is a very great success, for those patients. So there is future for those patients, and actually we have to treat them, and we have to be aware that we have the reversal agent, and that we must give the opportunity for those patients.